I'm Dr. Karthik Natrajan, Associate Professor of Cardiology, UN Mehta Hospital. I'd like to thank CardioCon and Dr. Kamal Sharma sir for this very interesting session of a patient, of a 43-year-old patient, a female patient who comes with unprovoked pulmonary embolism within 2 years. So this is something which we deal with in our day-to-day practice very commonly. So we'll be discussing the etiology of the same, what will be the investigations that we'll carry out, and what should be the management of such patients. So basically, what is pulmonary embolism and how common is it? So pulmonary embolism is a life-threatening complication of venous thromboembolism. It represents a major post-operative complication. Pulmonary embolism is commonly seen in patients with deep vein thrombosis. More than half of these patients are asymptomatic. The mortality remains quite high, 10 to 30% at 90 days, utilizing the current treatment regimes. The incidence seems to be increasing from 3 per 100 to more than 6.5 per 100 in the past 15 years, accounts for about 15% of the total post-operative deaths. And the worst part is that 81% of the patients who have pulmonary embolism would not even know, or they would not know how it feels to have pulmonary embolism, and 50% would have not heard of the term pulmonary embolism. So it's quite possible that the patient who comes to you with the first episode or so-called first episode of pulmonary embolism would have had multiple episodes in the past and would not be aware of it. The basic pathology of pulmonary embolism: at least 90% of the pulmonary emboli, they originate from the major leg veins. The pathogenesis involves the interplay of an acute inflammatory reaction triggered by vascular endothelial lesions, hypercoagulability, and venous stasis. The key factors which contribute to hemodynamic collapse in acute pulmonary embolism is that acute pulmonary embolism, it interferes with both the circulation and the gas exchange. So basically, it is the RV which fails initially. There is an increased RV afterload, RV dilatation with an increase in the neurohormonal activation, RV ischemia, which ultimately results in decreased RV coronary perfusion, systemic BP, low cardiac output, decreased RV output, and RV failure, and ultimately the RV starts failing and the patient collapses. So RV failure is the predominant cause of death or primary cause of death in severe pulmonary embolism. The clinical presentation is varied. It's a diverse, and that is one reason why pulmonary embolism is largely remains undetected, because it can present as acute onset dyspnea, it can present as acute onset chest pain, pre-syncope, hemoptysis. Any patient who has shortness of breath and or rapid breathing, rapid heart rate, chest pain, sudden onset, which may be worse upon deep breath, should be suspected as having pulmonary embolism unless proven otherwise. And this slide shows the varied presentations of pulmonary embolism. So once you say diagnose a patient as acute PE, the most important, even before diagnosis, is risk stratification, whether the patient fits into a high risk category or not high risk category. So depending upon whether the patient is having shock or hypotension, if the patient is in shock, then it would be high risk, a blood pressure less than 90 millimeters of mercury, or a systolic blood pressure drop of more than 40 millimeters of mercury for more than 15 minutes. If not caused by a new onset arrhythmia, hypovolemia, or sepsis. And if the patient is not in shock and hypotension, you have some time to evaluate and classify the patient as intermediate or low risk. What are the diagnostic investigations in pulmonary embolism? So here is the main difference. If you come as a diagnosed case of first-time pulmonary embolism or recurrent pulmonary embolism, all the patients who are suspected to have PE should have a general medical history taken, a physical examination, and a chest X-ray. And then you evaluate according to the Wells or the Geneva score. So the two-level Wells score, where you classify the patients as either PE likely or unlikely. If the patient is having pulmonary embolism, likely to have pulmonary embolism, offer an immediate CTPA, or if it's not available immediately, you go for interim parenteral anticoagulation followed by a CTPA. And if the CTPA turns out to be negative, get a ultrasound done if DVT is suspected. If the pulmonary embolism is unlikely, offer a D-dimer. If the D-dimer is positive, get a CTPA done. And if it's not available, again go for anticoagulation till you get one done. We are all aware of the Wells score. I'm not going into the detail of the original and the simplified version, which classifies as PE. Ultimately, the idea is whether PE is likely or unlikely. The revised Geneva score has also been useful in predicting whether the patient has pulmonary embolism or not. Once the patient is, say, having a high risk PE and you cannot or you can go for a CT angio immediately. Well and good, get a CT angio done. If this is positive, then the patient may require some form of reperfusion therapy. If the CT angio does not show a CTP, obviously it's ruled out. You need to rule out other features. If the CT angio is not available, which is very common, or the patient cannot be shifted to the CT scan, then you look at the echo. Look for signs of RV overload. If the patient is having RV overload, yes, then you go for a CT when the patient gets stabilized. And then if the CT shows pulmonary embolism, you need to go for primary perfusion. Or if sometimes you cannot go for a CT, you can visualize the pulmonary embolism, or sometimes you have a very strong clinical hunch, you can go for primary perfusion without the CT also. For not high risk PE, you can have a more slow and steady investigative course. If the patient is classified in low or intermediate category or clinical probability, get a D dimer done. If it's negative, no treatment is required. Positive, CT angio. And if PE is confirmed, then treatment, and no PE, no treatment. If there's a high probability of PE, go for a CT angio directly. If the PE is confirmed, go for the treatment. And if there's no PE, no need to investigate further. And I'd like to add that, if a patient is coming with recurrent pulmonary embolism, like in our case, once you have stabilized the patient, you have given the treatment, I think the etiology of pulmonary embolism becomes very important. So if I come across a patient who is a female, 43-year-old, has come with unprovoked DVT within 2 years of treatment, then, factors like, say, APLA, antiphospholipid antibody syndrome, going for beta 2 glycoprotein levels, going for lupus anticoagulant, going for an ANA, and going for an neutrophilic cytoplasmic antibody, ANCA test, C-ANCA and P-ANCA, looking for the hypercoagulability causes, like, say, a protein C, protein S, factor 5 mutation, prothrombin gene mutation, sometimes even methyl tetrahydrofolate reductase mutations, homocysteine levels. All this constitute the etiology of recurrent pulmonary embolism. The reason for investigating these patients such a way is that you need to define the course of anticoagulation. Probably this patient would require a high dose anticoagulation or more aggressive anticoagulation of lifetime, because the patient has already had a second episode of pulmonary embolism. So once this patient comes with pulmonary embolism and you have the patient is high risk with shock or hypotension, obviously the treatment is primary reperfusion. Now the EASC classifies the 3 reperfusion strategies as either you go for systemic thrombolysis, you go for catheter directed thrombolysis, or you go for surgical embolectomy. If the patient is not having a high risk, or there is not high risk PE, you assess the clinical risk. You calculate the PESI score or the simplified PESI score. If the patient fits into intermediate risk, then there is sub classification as intermediate high or intermediate low risk. And the intermediate high risk of the population, which is nowadays more and more incorporated in the trials, and which is the region of interest for interventional cardiologists, because these are the patients in whom you can intervene either with a catheter directed thrombolysis or mechanical thrombectomy or suction devices or ultrasound guided devices for maceration of the thrombus. If it's an intermediate low risk, you can go for hospitalization, but you need just monitoring. You need to not be so aggressive in interventions. And if it's a low risk, you do not need to admit the patient at all. Consider for early discharge and home treatment if feasible. The treatment of pulmonary embolism, obviously anticoagulation. If the patient is hemodynamically unstable, he would require some kind of respiratory support, a BiPAP, or sometimes invasive ventilation. He would require hemodynamic support, fluids, inotropes, anticoagulation, or any RV support devices if available. Anticoagulation is the primary treatment in any kind of pulmonary embolism. So parenteral anticoagulation has to be given: vitamin K antagonists, the NOACs, the new oral anticoagulants, thrombolytic therapy, surgical embolectomy, percutaneous catheter directed treatment, and venous filters. Anticoagulation therapy in patients with acute PE, it is recommended. Objective is to prevent both early death and recurrent symptomatic or fatal venous thromboembolism. The standard duration should cover at least 3 months. The guidelines ideally say that if it's the first episode of unprovoked DVT, or if it's provoked DVT or unprovoked DVT, the first episode, consider giving the patient anticoagulation for at least 3 months and preferably up to 6 months. So acute phase 5 to 10 days, standard duration 3 months, extend beyond 3 months. So parenteral anticoagulation when the patient is in hospital with either unfractionated heparin, low molecular weight heparin, or fondaparinux. Then for the long-term oral therapy, either consider warfarin or the NOACs. and look at the provoked risk factors, like say an oral contraceptive pills. In this patient, especially, one thing I forgot to mention is the OC pills. Always take a detailed history of the patient's OC pills, the menstrual status, which can provoke or increase the risk of developing venous thromboembolism and pulmonary embolism. So the provoked risk factors should be avoided. And obviously, in those patients who have unprovoked DVT, you can consider continuing it for 6 months and then stopping it. But in this our case, when the patient is having a recurrent pulmonary embolism, there is without a question a need for continuing the anticoagulation lifelong. Obviously, warfarin has been replaced by the NOACs for numerous reasons: unpredictable response, narrow therapeutic window, routine coagulation monitoring, frequent dose adjustments, slow onset and offset of action, numerous food drug interactions, numerous drug interactions, and risk of bleeding. The NOACs, the oral DTIs, that is dabigatran, and oral factor 10A inhibitor rivaroxaban, apixaban, and edoxaban, we have multiple trials showing their benefit over warfarin, that they are equally efficacious and with less bleeding. So the dosing of dabigatran, you just need to look at the creatinine clearance, which is the absolute contraindication if it's less than 30. Otherwise, any patient who is more than 75 or the creatinine clearance between 30 to 50 or high bleeding risk, you may need to give a lower dose of dabigatran, which is 110 milligram BD. And if the patient is say not having any of these factors, you can easily or safely give 150 milligram BD of dabigatran. Just make sure that the patient has to receive heparin for 5 days, either low molecular weight or unfractionated, and then you need to abruptly start dabigatran the very next day. Obviously, as I said, the duration has to be depending upon whether it's provoked or unprovoked, whether it's the first or second episode of DVT or PE. Dose of apixaban, everyone is aware of it. 10 milligram twice daily to 5 to 10 milligram twice daily. Rivaroxaban is 15 mg twice daily, then 20 mg once daily. This is the 10 mg dose apixaban for 7 days and then 5 mg twice daily. This is the transition. How do you transition from an anticoagulation to a NOAC? So if the patient is receiving IV heparin infusion, if you want to stop or change to a NOAC, stop it and commence NOAC immediately. If the patient is again receiving LMWH to NOAC, stop LMWH and commence the NOAC when the next dose is due. From warfarin to NOAC, stop warfarin, measure INR daily, wait till it's less than 2.5 and then commence NOAC. And this is again switching from dabigatran to warfarin and warfarin to vice versa. If you want to switch from warfarin to dabigatran, obviously, as I said, INR should be less than 2 to 2.5 and then start dabigatran. And if you want to switch from dabigatran to warfarin, recommend start of warfarin after squinting dabigatran 3 to 1 days depending upon the creatinine clearance. And these are switching from dabigatran to from parenteral and vice versa. And what is the discontinuation of dabigatran before scheduled surgery interventions? It should be 1 to 2 days before the procedure if the creatinine clearance is more than 50. If it's less than 50, 3 to 5 days. And if required, idracizumab, which is the antidote of dabigatran. These are the clinical evidences. NOACs, obviously, much more superior, multiple randomized trials, less bleeding, equally efficacious. All the NOACs, dabigatran, rivaroxaban, apixaban, edoxaban. The guidelines have almost always advocate that in patients who have a requirement of long-term therapy, then you give either of the NOACs which you have over vitamin K antagonist therapy. The key message is that PE remains preventable, and by combining patient presentation, clinical suspicion, and scoring systems, the diagnosis may be streamlined, and any patient who's coming with recurrent DVT needs to be investigated thoroughly, because with the investigations that I suggested, because these patients would require lifetime anticoagulation, more aggressive monitoring. There is a little data also suggesting that those patients who have hypercoagulable state, some of the hematologists feel that warfarin is probably a better choice if the patient has had such recurrent DVT. But again, that is questionable. There is no trial comparing warfarin with dabigatran or rivaroxaban or apixaban in a patient who has had recurrent episodes of VT on any of the NOACs. So we need more data for the same. But obviously, the first choice would be a NOAC because these are much safer and much or equally efficacious as compared to the vitamin K antagonists. By streamlining transition of care, facilitating out of hospital treatment for NOACs are easier to use, and because they're easier to use and safer than warfarin. Even if treatment in these patients start with MWH, you can always switch from a NOAC to a NOAC or from NOAC to warfarin as and when required. And compared to vitamin K antagonists, NOACs are not only effective in treating PE, but they are also safer in terms of bleeding, thereby conferring clinical benefit. And we are, I think, still in pulmonary embolism, the treatment of pulmonary embolism, we are in a stage where I think we are midway. The catheter directed treatment is very exciting and is evolving day by day. And even the NOACs, I think they are becoming more and more efficacious. So I think it is better that NOACs replace VKAs, but uh, warfarin will still remain a standard against which all the other things would be compared. Thank you.